Hello, Ed Brandt here again. I thought I would get right into some of the shortcomings or miscalculations in execution that other dentists have had trouble with to reinforce some points that I made in part 1 of the video on how to convert a flipper to a screw-retained, implant-supported, immediate provisional. This is a before and after. The top picture is the immediate provisional. The bottom picture is the final prosthetic bridge, supported by 3 implants. The patient had no trouble with the appearance of the immediate provisional, but I think you would understand that the patient was unhappy with the appearance of the final prosthetic bridge. This just underscores the importance of pink and white aesthetics, which is one of the key advantages to converting a flipper to a screw-retained bridge. Please make sure you work with a lab that is going to make you and the patient look good, and it never hurts to be as specific as possible on the lab prescription. Next, these are Nobel Biocare implants with some sort of rogue, aftermarket temporary abutments. There are 2 things wrong with this choice of temporary abutment. Number 1 is that the temporary abutment is too wide. When an abutment like this is chosen, you do invite complications. The temporary abutment can actually hang up on bone, making seating of the abutment incomplete. You will think the screw is down and fully seated, but in actuality, the abutment is not fully seated because bone is interfering with full seating. Secondly, this type of temporary abutment is too wide and can lead to crestal bone loss. We have enough trouble maintaining bone at the alveolar crest. The last thing we need is a temporary abutment that is too wide. The film on the left has the rogue temporary abutments that we've been speaking about on these Nobel Biocare implants. The X-ray on the right has Nobel implants with Nobel temporary abutments. We want to use brand name parts with brand name implant fixtures in these types of cases, in these types of immediate provisional cases. Don't be putting Ford parts in a Chevy. On the left, you can notice a big problem with choosing aftermarket temporary abutments. Only the very tip of the screw is actually holding the temporary abutments in place. The screws don't engage enough threads to provide ample clamping force. Sure enough, there were screw loosening problems with the case on the left. Contrast that to the X-ray on the right. The screws engage multiple threads inside this implant. Screw loosening is a big problem, so try to use Ford parts in a Ford and Chevy parts in a Chevy. Screw loosening is a big problem, not only because of the pure hassle factor of needing to retighten the bridge, but movement of the prostheses can generate micromovement to the implant and can cause implant failure. Implant failure leads to unhappy surgeons, unhappy patients, and unhappy restorative dentists. Here, this slide shows Nobel implants with Nobel temporary abutments. However, the temporary abutment on the left-hand side is hung up on some bone. There is a clear space between the abutment and the implant body. The important takeaway here is take an X-ray early in your appointment. Once you take off the healing abutments and put on the temporary abutments, check with an X-ray to make sure that the temporary abutments are seated. In a case like this, the bone will melt away after several days, and then the screw will get loose. Once the screw gets loose, the bridge gets loose, and once this happens, movement of the bridge can impart movement to the implant fixture. This scenario sets up a strong likelihood of implant failure, which is exactly what happened in this case. So make sure you work with the right lab and the right surgeon. Bone needs to be contoured properly to allow for temporary abutment and the acrylic. This is a perfect example of not reducing the bulk of the flipper and contouring properly. This is the way the case presented back to me after 2 or 3 days post-surgery. The patient actually calls me up and says, "Doc, I think you should take a look at what my dentist did." Now, hopefully you're beginning to know why I wanted to get these couple of videos out to everybody. Significant modification to the prostheses is an urgent matter. If something needs to be done to make the bridge right, then it must be done quickly. connections and reconnections of the prosthetics to the implants needs to occur in the first 2 to 3 days post-surgery. Some people say you can go out as much as 7 days, but basically the point is the earlier you do it, the better. It's very important that you understand that mechanical fixation of the implant to the bone is highest at this early stage. So any modifications need to be done extremely early. There was no time to waste in this case. The bridge was removed, recontoured, and then reconnected. Here is another case gone wrong. What do you think is going to happen if you screw this bridge down on the day of the implant surgery and allow it to heal? Well, connective tissue fibers are going to heal around the height of contour of the temporary abutment, and the soft tissue fibers are going to lock this bridge in the mouth. And that is exactly what happened. The dentist attempted to retrieve the bridge at the impressioning appointment, but the bridge would not release out of the tissue. This patient needed to undergo surgery to sever the fibers. Before the bridge could be reinserted, acrylic needed to be added to the height of contour of the temporary abutment. Just remember not to allow acrylic to go past the height of contour. Acrylic needs to be floated to the height of contour but not beyond. The bone likes the titanium temporary abutment more than it likes the acrylic. We do not want acrylic to irritate the bone. Remember, you are very close to the implant abutment interface, but also the bone to implant interface. Let's all do our best to maintain as much of the crest of bone as possible. On the left, you'll see the bridge without proper contour. On the right, you will see the bridge properly contoured. Notice how there is a gentle emergence of acrylic. In addition, you should remember not to bulk up the proximal surfaces too much. Otherwise, you take the chance of acrylic impinging on the bone and hanging up the bridge. If you don't leave enough breathing room between the acrylic and the bone for the soft tissue to proliferate, two things can happen. You will not get full seating of the bridge with subsequent screw loosening, or the patient will be in pain until the bone melts away. So again, notice how the acrylic gently slopes out from the height of contour of the temporary abutment. This is what it should look like. I just wanted to remind everybody that whenever you perform immediate temporaries in partially edentulous cases, you are looking for non-occlusal loading. So there is no occlusal contact. These teeth are for looks only. In addition to no occlusal contact, I believe there should be no interproximal contact, or at the very least, extremely light interproximal contact. Why? Because adjacent teeth can cyclically load the implant fixture. Remember, there is research out there that says that implant failure can occur if the implant fixture moves more than 20 microns. Unfortunately, a natural tooth can have physiological movement by as much as 200 microns. If there is interproximal contact, the fear is a rubbing or side-to-side movement can occur and cause micro-movement of the implant fixture. So please check your interproximal contacts and purposely leave them open or very, very light. So to end up, I wanted to give you some helpful hints on how to make your life a little easier at the beginning of this procedure and also at the end of the procedure. Number one, you may want to consider fabricating a matrix just in case there is a problem. I've seen two potentially devastating problems upon grinding the denture to make the access holes. I've seen the denture crack in 2 or more pieces, and I've seen teeth flake off the denture. I haven't seen it a lot, but it can happen. You may want to consider fabricating a matrix before you start creating the access holes. This will allow you to easily lute back a tooth on the denture or lute the bridge back together. In addition, you may want to choose your acrylic burr carefully. My suggestion would be to use a spherical acrylic burr. I would stay away from the use of an oval type of acrylic burr, or if you're going to use it, make sure it's very sharp. I believe they have a tendency to jam themselves or get stuck in the acrylic. Another great restorative tip that many restorative dentists seem to appreciate is this helpful hint. on retrieving prosthetic screws in the access channels. Simply squeeze the tip of a surgical suction tip with a needle holder. Most often, the screw gets sucked up the access channel and is able to be pulled out by the assistant. I've gotten more thank yous from this helpful hint than any other. I hope you utilize this tip and like it. My last tip is in regards to using Teflon tape instead of cotton to fill the access channel. You should know that Teflon tape can be found in pool supply stores, at Home Depot or Lowe's, or in your household plumbing bucket. The Teflon tape can be autoclaved to make it sterile. It does have a tendency to shrink, so put more in there than you think you need. I like to fold the Teflon tape over on itself, roll it up, advance the Teflon tape, and condense the Teflon tightly into the access hole with a perio probe. Fill the Teflon tape just shy of the top of the access channel. I would shoot for 2 to 3 millimeters shy of the top. Firmit is typically used to cap off the temporary abutment. Firmit has some great working qualities. It's easy to work with, and it's easily removed when necessary. Excess Firmit is removed with an alcohol-drenched finger or alcohol-drenched Q-tip or gauze pad. After the excess is removed, the Firmit is cured. So we're at the end. Here I'd like to just list all the critical points that we mentioned for future reference. Converting a flipper to a fixed, screw-retained provisional is not the only way to render this care, but I believe if you follow all the steps outlined in these 2 videos, you will have success with an absolute minimal chance for complications. Quite honestly, whatever method you choose to use for immediate temporization, you will need to follow the guidelines spoken about in these 2 videos. So, the next time you have a case where lower incisors need to be removed, I believe you should be thinking about immediate temporization. The bone is typically dense enough for proper fixation of the implants, and the occlusion is most often easily protected. Armed with the knowledge of these 2 videos, I believe you can successfully render this care. As always, thanks for watching, and if you have any negative or positive comments about the videos, please reply to the email.